Well, hello, I'm Bob Hall. I work for APTA Orthopedics, as well as the State Payment Advocacy Resource Consortium, or SPARC, which I hope you get the chance to visit at the APTA website. Helps with payment issues specific to state-regulated payers, but many of the resources are available for all kinds of advocacy, and we really encourage folks to start taking on that as a responsibility of being a physical therapist. Payment is a huge issue, and in order to solve that, we all need to engage in advocacy. What I want to talk about today is the physician fee schedule, another opportunity to advocate, and why physical therapists should pay attention, what it means for 2026, and how you can get involved. The first issue, and I'm going to go through 5 of them, is the conversion factor. And this is a very technical issue, but it is something that leads to downstream payment. Essentially, what happens is the Relative Value Update Committee of the Medicare or the American Medical Association provides a relative value units to CMS, and then CMS publishes those relative value units, divides them up into sections, and then multiplies those by the conversion factor that then gives you a dollar figure based on the code that you claim. So what's interesting about this version of the fee schedule, because it comes out every single year, we always get a draft version in the summer, and then it becomes finalized normally around end of October or early November for the next year, is that there are now 2 different conversion factors. One associated with alternative payment models, so folks that are interested in value-based payment, who may have signed up for a qualifying APM, actually will be paid more now versus those who are not in a qualifying payment structure that Medicare considers to be an alternative payment model. So what's going to be interesting about that, it's really not that big of a change. It's 0.21% of the conversion factor change. So basically, if you're in a qualifying APM, the conversion factor is $33.59. If you're in a non-qualifying structure, it's $33.42. So really only 17 cents different, but because it gets multiplied, it does have a larger impact based on the RVUs that are associated with the codes that folks will claim. So bottom line, though, beyond that technicality, if you're in an APM, you'll be paid more. And the idea behind that is Medicare is trying to incentivize folks to go into APMs, these new value-based payment models, so that we start getting away from a healthcare system that is paid based only on how many services are provided versus what actual health is in the end based on those services. So it's a good goal. I think a lot of folks would agree with it. The implementation, though, has been incredibly problematic. And it's just a really hard thing to nail down health. It's a really hard thing to nail down appropriate quality measures, which sort of drive or provide the engine to determine whether or not something is really an alternative payment model. And really, because physical therapists are not generally the sort of default, doctors really are thought of to be physicians, are the ones who oftentimes are thought of in alternative payment models. It's really hard for us to fit into many of these alternative payment models. But APTA Orthopedics is very engaged in this issue, so is SPARC. Quality measures need to be approved for physical therapy, and we're working on that with APTA, which is really leading the charge on that. So we're hopeful more and more PTs can fit into that higher payment rate because they're going to be in a qualifying APM or alternative payment model. That's the first thing. Second thing is an efficiency adjustment actually may lower a component of the RVUs called the work RVUs. So CMS intends to apply a 2.5% decrease in efficiency adjustment to non-time-based codes, reducing work RVUs based on presumed productivity improvements. For PTs, that means because many codes are time-based and thus exempt, numerous adjunct services like modalities could see downward adjustments. We need to monitor which specific codes may be affected, and we're going to do that as we move forward through this process and throughout next year. But it is important to recognize that some RVUs, work RVUs, may be decreased. Again, pretty technical, but could impact downline payment rates and important for us to pay attention to. The third thing I wanted to talk about is the expanded telehealth and virtual direct supervision component of the draft rule. CMS proposes in the draft rule to simplify telehealth rulemaking and permanently allow audio-video direct supervision, virtual direct supervision for certain incident to services, including pulmonary rehab. This opens the potential for remote supervision of PT assistants or telerehab services that could conceivably boost access and flexibility, especially in rural or homebound settings. As we all know, it's hard to get folks in the practice or in the clinic when there aren't that many clinics in a rural area. So it's a really important opportunity for folks who may live in more less populated parts of the country to get physical therapy services and really be able to improve their health by using those high quality, low cost modes of care. So we're hopeful that this will actually allow more access to PT over time, but we need to see how this plays out. And also there's a congressional component here. We'll see how long Congress will be willing to pay for telehealth. That's what good lobbyists are doing, is trying to make sure that all this stuff stays available for people, especially in these areas that are underserved. The fourth issue is the practice expense methodology revision. The PE component of RVU payment and CPT codes is being revised. The PE computations are being revised to reflect higher indirect costs in office settings, and considering the hospital outpatient prospective payment system data instead of relying only on dated AMA surveys. I believe there was a New York Times article about this, and it's important to recognize that this is one of the, could be a very important long-term change that, Medicare is looking at. Historically, like I'd mentioned, the AMA's RUC was the one that provided valuations for different CPT codes, but CMS seems to, with this, be stepping away to some extent from reliance on the AMA only for that information. Instead, the outpatient prospective payment system data, that may be used additionally or in lieu of what some of the information is that the AMA provides. So for PTs, clinics may see higher office-based PE valuation, potentially enhancing reimbursements for PTs delivering services in private settings versus facility settings. And we would encourage APTA to advocate for PT-specific cost data inclusion in future updates. If physicians get it, we ought to be able to get it too. And I think it's important to just take a step back here. There is a difference in payment between folks who are in private practices and folks who practice in hospital settings. It's historically been seen that hospitals have a higher acuity of folks who come in. They're sicker, essentially, if they're oftentimes receiving care in a hospital setting. And that's been essentially one of the major justifications for differentials in payment between hospitals. Interestingly, and this matters for the State Payment Advocacy Resource Consortium, the APTA private practice section is not in favor of things that change levels of payment based on the site of service that the care is provided in. So even though this might have a benefit to some private practices, generally APTA private practice has shied away from saying it should be up to the payer or Medicare to determine how much should be differentiated in payment. I think the bottom line concern is I think, APTA private practice in particular would like to see private practice rates go up to hospital rates, as opposed to hospital rates coming down to private practice rates. We want to make sure that PT is adequately reimbursed in no matter what setting, and we don't want to see a race to the bottom based on differentials in what Medicare values for a site of service. So we'll see what happens with that. Again, a really potentially major break in the way that Medicare has looked at how to value services, and potentially important based on the site where some of those services are provided. The last thing I'll speak about, the fifth thing, is PTA supervision and plan of care relief. So though this isn't explicitly in the 2026 draft, CMS also flagged progress on longstanding items relevant to PTs from recent and adjacent proposals. So PTA general supervision, right? We've seen an ongoing shift from CMS from direct to general supervision in Part B settings. That's a great thing because it makes it easier for people to get PT services, whether it's provided by a PT or a PTA. We want to see those PTAs extended under the supervision of PTs and provide more care to folks in areas that may not have a plethora of PT practices available. So it's really important, especially in rural areas, underserved urban areas. We want to make sure folks can get physical therapy care. Then the plan of care orders. This was a major change that happened this year. It's going to be continuing throughout next year. And basically what this does is it allows physician referrals to serve as initial plan of care certification, and this greatly reduces the paperwork burden. In speaking with physical therapists, I've just heard over and over again what a waste and a pain it is to try to chase physicians' offices for signatures on things that the physician knows is already happening. And basically ordered to begin with. And also it was very challenging to continue plans of care and make sure physical therapy services were provided without interruption, even if a signature was missing. It was just not great practice. The paperwork was absolutely getting in the way of the care. So we were really happy when CMS proposed this change last year. It looks like it's continuing, and we're very happy about that. We'll certainly be commenting on this and why it matters. We want to make sure that that's finalized because it would increase efficiency and reduce administrative burden, and of course, from a practice perspective, improve practice workflows. So overall, I'd say that this was a pretty good fee schedule. We had some wins here. We, of course, want to see payment increase across the board, not just for APMs. And there is a component here that's going to be based on whether Congress continues to fund Medicare adequately. But we'll see where that goes. And we'll certainly be advocating to make sure that the gains that we make in this fee schedule continue on when the rubber hits the road on January 1st of 2026. We'll be commenting, and we'd love for you to get engaged as well with the APTA's comment tool. You can do that by going to the APTA website. We'll get a lot more resources out for folks, and there will actually be a video webinar on August 7th that'll be available from APTA. Encourage you all, if you have more questions, to go to that to try to learn a little bit more about what this might mean for you and the physical therapy care that you provide. Thanks so much.